Cure has 8 world-class facilities in India and 1 facility in US. This is an initiative by MCure Pharmaceuticals Limited, Xenex division, in order to disseminate the latest happenings in the field of medicine through a series of webinars by eminent experts and renowned faculty from various fields. Today's webinar provides everyone an opportunity to learn and understand the recent advances in the field of orthopedics. We are really proud to be associated with all of you through this webinar. The topic for today is diagnostic shoulder arthroscopy and decision making in slap tear. To enlighten us on the subject, we have with us today Dr. Arnab Karmakar, who is joining us from Kolkata. We have an exciting agenda for the next 1 hour. We take a great pleasure in introducing the speaker, Dr. Arnab Karmakar, sir. Dr. Karmakar is a consultant orthopedic surgeon in Kolkata. He has done his fellowship in arthroscopy and arthroplasty from Adelaide, Australia, under Flinders University in 2015. He has also topped the university in his MS orthopedic examination in 2013. He has also done his DNB orthopedic surgery and MCH orthopedic surgery, which he has completed in 2016. He has done a poster presentation in SICOT World Congress in 2013. He has got a paper in gold medal session in IOCON 2013. He has presented papers in arthroscopy in ISKSAA 2018 at Leeds in UK. And he has been elected the executive committee member for West Bengal Orthopedic Association 2019. So I request the audience to actively participate in this webinar and put your questions in the chat box, which I'll be putting across to Dr. Karmakar. Sir, thank you very much for accepting this invite to conduct this webinar. Also requesting the audience to please mute your mobiles and close your video so that sir can start the session. Over to you, sir.
Thank you. Thank you. It's a great honor and great pleasure to talk with all of you. And it's always, delightful to share knowledge. I think this is the best way we can utilize this time, and if we can enrich ourselves together with the pharmaceutical companies as a doctors. So I think that is the best possible thing we can do now. And the video was really very inspiring, and we doctors need those inspirations and helps from you, from your side, so that can help us to serve the humanity better. So the topic of today is very, very interesting, and I kept it mixed with some basic and some advanced. But what I think that being there are a lot of webinars there on, especially on surgical videos and all. So I kept it on practical aspect, that how a surgeon or a doctor who is actually seeing a patient can judge the thing and take a proper decision. So decision making is the most important for the clinicians. So initially I'll start with a basic shoulder arthroscopy, diagnostic arthroscopy, because it's the most important and essential thing to diagnose anything in shoulder before you going for any operations like Banker's repair, like a slap repair, like a cuff repair, whatever you want to do. Before that, it's utmost importance that you identify all of the anatomical landmarks properly, and you master the tricks how to go in and how to see all of the things. Then on the latter part, we'll discuss what is actually slack tear, how you can assess a slack tear, and how you can decide on whether you are going to do something with that thing or you are just going to be conservative. So initially, I'll start with the basic shoulder arthroscopy, and I request to all the participants that whatever doubt you have in your mind, please put all these things so that we can have a good discussion. So clear your doubts here only. That would be great. So basics of shoulder arthroscopy. So basically, sometimes though it has not been promoted as a diagnostic modality for any shoulder pathologies or diseases, but it's of utmost importance that you put your scope through a proper portal inside the joint, and you look inside the joint properly, you have to see and identify all the important anatomical landmarks to identify any pathology. So to identify any pathology, you need to understand what is the normal, what is the proper anatomical thing. So first, we'll take a few minutes times to discuss about the portals. So as you all know, this is a right shoulder which has been pictured, and this is the surface marking is for acromion. So this is the posterior side, this is the anterior side, and this acromion has been drawn. And so the primary or the viewing portal is the posterior portal. So how we can go into the posterior portal is that the posterior angle of the acromion, you can just go one thumb below and one thumb medial, or maybe 2.5 centimeter below and 2.5 centimeter medial to that point, and that corresponds to the posterior soft point to the shoulder joint. So if you can feel and palpate, so there is a muscle interval, and so you can straight away incise the skin and put your scope towards. So now when you are putting your scope through the posterior portal, how you need to. So before you are going into for making your portal, you need to understand, you need to identify all the clear anatomical landmarks. So what is the important thing in the anterior part of the shoulder anatomical landmark is the coracoid. So you have to palpate whole of the acromion, the posterior angle, the whole of the lateral surface of the acromion, the anterior bend of the acromion, the clavicle, the AC joint, and the coracoid. So all of this anatomical landmarks you need to palpate properly, you need to mark it properly, then you go for making your portal. So as I already told how you are making your portal, what is the anatomical landmark for making your posterior portal. Next important is the direction of your hand, where you can introduce the trocar and canthus within the joint. So how you can go? So hold your shoulder joint with your left hand and then push your trocar and cannula. So how? With your index finger, palpate the coracoid. This is valid for this right shoulder of this patient. So palpate the coracoid and try to introduce your scope towards the coracoid. So direction of pushing of your trocar cannula should be towards the coracoid, and it should not be up or down. It should not be medial or lateral. So just you go inside the skin and try to push and pierce the posterior capsule of the shoulder and introduce in the direction, in the trajectory of hitting the coracoid. Then only you will be easily going inside the joints. Otherwise, you will be hitting in the posterior part of the humeral head. You will be hitting in the posterior part of the acromion. You will be damaging the structures around. So this simple trick should be kept in mind before you are going inside the joint. Then other important portals are the anterior portal. If you can see, so if you can palpate just coracoid, anterior portal is just lateral to the coracoid. And always keep in mind that red flag in shoulder arthroscopy, never go medial to this coracoid. So coracoid should be your boundary. You should not go medial to this coracoid. If you can see the AC joint, that is also at the level or slightly lateral to the coracoid. So because in medial to coracoid, all the important neuromuscular structures are there. So you should not go medial to coracoid. So anterior portal is actually done under direct vision. So whenever you are going inside the joint, we interval and then we put a needle from outside in. So it is done by outside in technique and it is done by under direct vision. So these are the two basics. So one is viewing portal, one is working portal. So if you want another important or anterolateral portal can be added there, that can be 2 finger breadth lateral from the anterior portal, and there is a working lateral portal that you palpate the acromial surface, give 1 finger gap and you go inside the joint. So lateral acromial portal is required for any work in the cuff area or in the subacromial space. That means either you want to do a subacromial decompression or if you want to do repair. So that in those cases, these lateral subacromial portals are required. But for any intra-articular section or procedure, this posterior and anterolateral portal is more than sufficient. So what are the things and what should be the algorithm of doing a diagnostic shoulder arthroscopy? Because it is a mandatory before doing any procedure in shoulder. So first you go inside and try to locate the biceps tendon. Okay, so I'll show you a video with all of this just to keep in remember, because this should be kept in your mind as a rhyme. So this should be a rhyme so that you go and you just go in the flow into the shoulder joint. So first you locate the biceps tendon because it's the lighthouse for shoulder joint. So once you have located the biceps tendon and the superior labrum, because you know how this biceps tendon is actually inserted in the 12 o'clock position of this glenoid labrum. So whenever your biceps press up to the superior labrum. If you can come, then the number 2 is posterior lumbar. So slightly withdraw your scope, come into the posterior side of the joint. You can see posterior labrum and posterior capsular recess. Then go down. So you need to keep your hand up so that your scope will go down. So once you keep your hand up and scope will go down to the joint, then you will be into the axillary or the inferior capsular insertion of this humeral joint. So this will be the axillary pouch of the shoulder joint. Whatever any collection will be there. Next, you see the inferior labrum and glenoid articular cartilage. You come back in with the joint. Then you go into the superior part and see there is a supraspinatus tendons of the rotator cuff. So number 5 is a supraspinatus tendon in the rotator cuff that inserts into the humeral head. Next, you see the posterior rotator cuff insertion in the area of the humeral head. So here only you will find the Hill-Sachs lesion. So anything will be there in the number 5 and number 6. So you come into the joint, then you see, identify the supraspinatus, then you slightly retract your scope and slide your scope through the humeral head in the posterior part of the humeral head. Here, there you have to look for any Hill-Sachs lesion or in the integrity of the posterior cuff muscle. Next, you finally examine whole of the articular surface of the humeral head. So at this position, you can rotate the arm, internal and external. You will see whole of the humeral head articular cartilage. So it's not only about your scope and other thing, it's your position of your hand and position of the patient's arm, which will actually make you understand 360-degree view of the shoulder joint. Next, another important thing, once you finalize visualizing the cartilage of the humeral head, then you come to the important thing is the anterior superior labrum. So you trace that labrum from the anterior part, so anterior superior, superior, and all these glenohumeral ligaments and the subscapularis tendon. So subscapularis will be horizontal, parallel to this root, and it will be from the glenoid to the humeral head. So you need to identify the subscapularis tendon and all the glenohumeral ligaments. Then you need to identify the anterior inferior labrum. This is most important for any Banker's lesion. That is a Banker's lesion you need to identify, and any ligamentous laxity or ligament injury. So this is the visualization you should do from the posterior portal from the shoulder. So all these 10 points you need to identify, you need to see, and you need to follow one algorithm so that you don't miss anything. There are certain conditions where you need to put your scope from the anterior portal to look in the posterior compartment of the joint in a proper manner, because from the posterior portal it's not very easy to see all the posterior structures. So what are they? There might be some special situation. So if you need to check for any posterior labral injuries or labral some diseases, so you need to go from the anterior part. If you need to see the posterior part of the joint capsule, then you need to go from the anterior portal. Posterior part of the rotator cuff, including the infra and the supra tendon, can be seen better from the anterior portal. Anterior labrum and inferior glenohumeral ligament attachment to the humeral head. So all this ligamentous attachment to the glenoid can be easily seen from the posterior portal, whereas if you want to see those attachment to the humeral head, because there are sometimes avulsion of this subscap tendon and these ligaments from the humeral head, so those things can be better seen from the anterior portal. So anterior surface of the humeral head with subscap attachment and biceps tendon through the rotator interval. So all these things can be seen better from the anterior portal. So this is a bit of advanced thing, but for beginners or for everybody, so first 10 points we discussed has to be done, and that rhythm should be followed. So just go through this video carefully. Every point I have tried to make simple, and all the important structures you need to try to identify. So if at all you have any doubt or query, you can ask me at the end of this lecture. So I think it will be easy. So as I told, so once you go in from the posterior portal, you need to see the long head of biceps. So this white broad structure, it is the long head of biceps. So it's actually coming out from the superior part. So it will be around, look around. To your left will be the slab, superior labrum, and to your right is the head cartilage, whatever we are saying. So once we are inside, to identify, we need to look for, see, left, on the left is the glenoid articular margin, on the right is the humeral head. So you examine both the articular surfaces. Bare spot on the glenoid also can be seen. So this is the joint. Then you retract back and you try to see the posterior labrum. So from towards left is the posterior labrum we are looking at. So once we've seen the posterior labrum, we are going down. As I told you, you keep your hand up and put your scope down. So once you are going down, you can see the inferior recess and you can see how this capsule is going inserted in the humeral head. So you can see the capsule nicely. So you need to look for any Hagel lesion. You need to look for there might be avulsion of the glenoid capsule from this glenoid and this humeral head. So all these things might be there, and if in case of any degenerative joint disease or some problems, loose bodies may be found in this inferior recess or pouch. So once you are through this inferior recess, you rotate and then come back to the posterior part of the humeral head, that is the bare area. Here you need to identify the Hill-Sachs lesion. Next you go up, now you see the insertion of the cuff to the humeral head. So this is the posterior cuff. This is the superior cuff or the supraspinatus. So now we are going anterior to it. You can see how biceps tendon is entering. Okay, so the bicipital group. So this is the biceps tendon entering the bicipital group. And you have to look carefully for the biceps pulley, for any inflammation, for any fraying, all these things you need to check. Next, once it is done, you go anterior, and I told you the one horizontal tendinous structures will be there. That will be the subscapularis and the superior glenohumeral ligament. All these things will be there. So this interval is actually where we are going to put our anterior portal. This is the MGHL or the humeral ligament. So this anterior portal should be from this area where just above the subscapularis tendon. So next you come to the anterior and you can see the anterior labrum. We have to look for any Banker's lesion there or any capsular avulsion from the anterior inferior area there, and you have to check for mobility, and then you have done all these things. So from the anterior side, all the three mid glenohumeral ligament and all the subscap muscles. So once you have done, if you can see this area just above this subscap muscle, we will to come from the anterior side, and with the needle we will come through and then we'll pierce into the anterior portal. So anterior portal would be under vision. So this is the basic steps of diagnostic shoulder arthroscopy. So all these 10 points you need to understand. Once you master this technique, I think we are ready for the advanced thing, because this is really must. So here I finished my first lecture. So if there is any question till now, we can answer that, or I'll straight away go to the decision making for the slap lesion. Because once if you have to take a decision on any treatment, whether you are or you are not going to intervene, you need to understand the pathology. You need to check. Sometimes even after doing MRI or MR arthrogram also, we are still in doubt whether there is a tear or not. So in that case, you may have to go for a diagnostic scopy. Then you may have to take a decision on table that whether you are going to put any anchor or you are just going to debride and leave it. So that is very, very important. So do you have any questions till now, or I'll go to the next one?
No, sir. No questions have come. Sir, you can continue.
So I'll start with the next one, that is a decision making in slap tear. So that we can take questions at the end of the session. So fine, no problem. So whenever there is a question, you can tell me. So we'll talk. Right. So as you all know that superior labra, as we shown in the diagnostic scopy video, so it is a very integrated structure which is attached to the biceps pulley. So whenever there is an origin of the biceps tendon, long head of biceps tendon from the superior part of the glenoid, and there is also attachment of the labrum in the superior part. So times we may see some of these cases where there are associated slap tear along with a banker's tear, along with a banker's injury or lesion. So at times we are confused that whether we are going to do something or not. So let us have put some light on that so that you can take a decision whether when we can intervene in a case of tear. So you know that to discuss a basic anatomy is that labrum capsule and biceps tendon and subscapularis all are derived from the same embryology. So that is why their blood supply, their nerve supply, and their integrity of the structures are sometimes interrelated, and their problems are also sometimes interrelated. And the glenoid labrum, it's a fibrocartilaginous tissue with sparse elastin fibers in them. They act as a transition between the hyaline cartilage of the glenoid and the fibrous joint capsule. So the once there is a cartilage, then is the labrum, then is the joint capsule insertion. So inferiorly, the labrum blends with the articular cartilage of the glenoid, functions as a stabilizing a load-sharing structure, and serves as site for ligamentous attachment. So this is very, very important. So if it is not like that, it's only a slap tear. If it has been a slap tear, it may be associated with a tear or avulsion of the long head of biceps, or tear or avulsion of the joint capsule, or tear or avulsion of the. So you need to see all of them as a whole, not only as a separate thing. So if you can see on an end-on view on the glenoid cavity, you can see the white structure is the labrum, which actually encircles the glenoid cavity, and it increases the contact between the humeral head and the glenoid cavity. Because shoulder is like a ball on a plate. So how a ball can be stabilized on a plate? So you need to make that into a cup. So that is a function this labrum actually does. And if you can see the tendon of the biceps, how actually closely it is related, and whole of the joint capsule is actually attached to this labrum. So whenever there is a injury to the labrum, it is actually also makes the capsule loose. So there may be a chances of instability. There may be a chances of pain also. Okay. So those important things you need to understand. And just above the superior labrum is the rotator cuff muscle actually coming and getting inserted to the humeral head. So it's a very important thing. It should be given proper importance. Few points regarding the biceps anchor. So it's a broad origin from the supraglenoid tubercle and the superior labrum at 12 o'clock. So that is why you always say that the biceps is the lighthouse for the shoulder joint. You need to identify and locate the biceps tendon. Then you are at the 12 o'clock position of the glenoid labrum. So from that, in respect to identify the anatomical structures. Supraglenoid tubercle is 5 millimeter medial to the edge of the glenoid rim. It has a variable origin. Some reports of 100% origin from the labrum alone. So sometimes it is not even inserted into the bone. Sometimes it totally come from the labrum. So in those cases, if the superior labrum is damaged, then your biceps tendons also may become unstable. So as we told you, the relation between the biceps and the labrum, it's very closely related, and it crosses and merges with the superior labrum and then gets inserted in the supraglenoid tubercle. So that is why, so that this origin of this biceps is very, very important and very closely related to this glenoid labrum. So you need to understand these anatomical variations. And the function, so as already we told that it attachment for the capsule ligamentous origin of the muscles, and it increases the contact between the glenoid head and the particular humeral head and the glenoid. So there are normal variations in superior. There might be a triangular, there might be a bumper shaped, there might be a meniscoid like a meniscus. There might be a sublabral foramina might be there, and sometimes there might be a Burford complex. Let us discuss all of them slowly so that you can understand. So this triangular labrum, here the labrum shows a shape of triangle. So initially from the superior part, it comes very shallow in a narrow angle. So it makes a triangular labrum. You can understand the biceps and the labrum. Sometimes it's a bumper, so it's a huge elevation like a bumper from the joint capsule. So that might be a better for stability, but it may cause impingement and pain and it's easy to get avulsed if it is such thick in manner. Meniscoid, so it will be, the breadth will be much more like a medial meniscus or lateral meniscus, which actually goes inside the joint. So it will be, breadth will be much more, and it will be, thickness will be much less. So it will be more like of meniscus. And a Bufford complex is it's a normal variation found in 1.5% of the normal human. So it's a cord-like medial glenohumeral ligament. So you can see the MGHL like a cord with apparently deficient lateral tissue below it. So once you go inside, you see that MGHL is attached with that glenoid labrum, but there is no labrum anteriorly, and so there is absent. So it can mimic with a Banker's lesion, but there is no history of injury and all, and usually may be asymptomatic. So it's a normal anatomical variation and rare complex. So it is called a Bufford complex. So definitions of slap lesion, it is coined, the term coined by the Sender et al. So superior labrum anterior and posterior to the biceps anchor. So in respect to the biceps anchor, any lesion which is in the superior labrum, both anterior and posterior to the, is called a slap lesion. So let us understand the classification of slap lesion, because to understand the management, we need to classify them. So this classification, you can classify broadly into A, B, C, D. If you can see and understand from the picture, is that type A slap lesion is a degenerative fraying of the superior labrum, whereas type B is the detached labrobicipital complex. That means the biceps tendon is attached with the labrum and whole complex has been detached from the glenoid bone. Type C is a bucket handle type of tear. So if you can understand the handle, we all know bucket handle tear of the meniscus. So half part of this labrum is actually torn and it's inverted into the joint. It's like a handle of a bucket. So it's the type C. And finally type D. So this superior labrum anterior and posterior, but this bucket handle tear extend with the biceps tendon. So that D is a bucket handle tear with the extension to the biceps tendon. So there are the basic Sender's four types of slap tear, but in real life, we see much complex scenarios. So that is why this classification has been extended. So type 5 is a slap tear that extend to the inferior aspect of the labrum. So it might be anterior, posterior, but it extends up to the inferior aspect. So along with superior slap, the labral tear, it extends into the inferior. Type 6 is a superior labral flap. So suppose your bucket handle, if get detached from one side, then it will become a superior labral flap. Type 7 is that slap tear that extend into the capsule. So along with your slap tear, there is also associated rent in the or rupture in the capsule. So as you go on, the injury becomes more and more. So the prognosis becomes bad and your requirement for a surgical repair becomes much more. There are extended type 8, 9 and 10. So if you can remember, okay, otherwise these are not essential to remember. Just to go on, that type is a tear with posterior inferior labral tear, which is very, very rare, and it is associated with posterior shoulder dislocation. That is why I'm telling you that this is very rare. Type 9 is a tear with extensive anterior and posterior extension. That means almost 360-degree tear of this labrum. Type 9 is a tear with extension to the rotator interval. So these are all very rare varieties and these are not very commonly encountered ones. So how a patient will come to you with a slap tear is that most often found after trauma in swimmers or long time overhead throwing athletes. It describes a clicking and popping, often associated with anterior shoulder pain, and reduced function, including decreased throwing or serving velocity or slower swimming speed. So any overhead activity, overhead abduction, repeated things can cause problem in a case of patients of slap tear. The symptom may appear suddenly or gradually depending on the type of the tear. Dead arm syndrome is characterized by the inability to throw at the pre-injury velocity. So throwers will always complain that they are not able to throw in that manner. So there are various tests to understand whether there is a slab tear or not. So these are the few tests. I'll just so if you can remember one or two of them, that will be more than enough, because it's not easy to do all these things. So best case is that if you do keep the shoulder 90 flexion, 10 degree of horizontal adduction, and maximum internal rotation with the elbow will be full extended, then you give a downward force at the wrist and try ask the patient to resist and elevate the arm. So then the patient will say there is a pain in the top of the shoulder or just below the AC joint. So the patient will show you. So there are many tests are there. So I don't think I will stress upon all of this. You can read it, all these things anytime. A patients with not properly treated or relieved of shoulder pain, and especially if they are talking to you that they are difficulty in keeping something in overhead abduction or throwing or some other problems, or players in bowlers and all these things, please do the test for slap tears. There are patients for, we get patients for missed slap tears. Only the banker's lesion has been addressed, but the slap tear has not been addressed. So all these things you have to, so you can go through. So next comes, once you have clinically identified that there might be some problem, MRI, definitely MRI is the investigation of choice, but it's not always detected in MRI, because it's a dynamic pathology, it's not a static pathology, and sometimes if the tear is subtle or very minimal, you can't see them. But MR arthrography is the best gold standards for detecting a slap tear, because we put a dye inside the joint, then this dye will go in between the glenoid bone and the superior labral if there is any injury, and this is high. So it's better to do this MR arthroscopy in abduction external rotation position, because that's the position when the slab gets displaced, and we can do it in different position. Even we can do CT arthrography also, but if you have the facility of MR arthrography, then it is best. So regarding the few points on non-operative treatment, slap one lesion predisposed to conservative treatment in absence of other things. So if it is only a solitary, we can try conservative treatment. Different physiotherapy, exercise, and other things are there. Regarding the operative treatment, so what are the options we have for operative treatment in slap is that first, debridement for some degenerative subtle tears. We can debride the tissue as we do in partial meniscectomy in knee. We can repair with suture anchors. This is very, very important. If that is causing displacement of the biceps anchor, if that is causing displacement of pain of the patient, or the patient is a high demand athlete or repeated throwing activity is required, then you need to consider a repair. And also address the biceps, either if it is degenerated, if it is diseased, you may try for tenotomy if the pain is the principal factor, or if it is a young patient and function is required, then you can go for a tenodesis. And also address the other associated pathologies like a concomitant Banker's lesion, Hill-Sachs lesion may be there. So this is a very big chart. Just one point I want uh, take from here is that there are many studies has been done after, if you can understand the heading, which is shown outcome after repair of superior labral and posterior. So all of them, almost 80%, all of them, if you can see, they say that surgical repair has shown very good results and very high chance of return to sport at least 90% of their pre-injury level. So that is very, very important. So you need to consider repair. So slap tear is not always manageable by conservative management. So decision-making factors, what are the factors? You need to understand the mode of the injury. So definitely a very old slap tear is not amenable to repair. So understand the injury, the duration, what is the occupation of the patient, what is the requirement of the patient, what is the age of the patient. Degenerative slap tear, debridement should be the best option. Young patients, demanding patient, try to repair it. And location of the pain. So any associated pathology. Suppose if it is from only symptoms is pain, even at rest, even in the night. So always try to check for any other pathologies, tendinosis, bicipital tendinosis, other factors which might be a rotator cuff pathology, other factors which might be a cause of pain. So that is why clinical judgment or clinical examination is very, very important. So if you can go in an algorithm for managing this slap lesion, so if you can find obvious biceps pathology from your test or invest, there might be tear or type 4. So if you can remember the type 4, that was a bucket handle type of tear along with biceps tendon. So if the tendon is torn or injured, you need to go for tendinosis. That means you need to address the biceps tendon. If it is not there, so if it has been other problems in the degenerative labrum or a rotator cuff tear, in such scenario, we also try to sacrifice the biceps tendon, because the important takeaway point is that the main point for pain generation in all factors is biceps tendon. So if at all, if there is any pathology in the biceps tendon, try to address the biceps tendon. Once you address the biceps tendon, most of your pains go away. So if this biceps tendon is okay, there is no pain, no inflammation in the biceps tendon, and other pathologies are also addressed, and there has been a history of trauma, and your clinical judgment says that there has been a slap tear, that means a traumatic slap tear in a high demand patients, excluding other biceps pathology, you should always try to repair the slap. So this should be the take home message for you, that you need to exclude the biceps pathology, address the biceps pathology, and traumatic tears should be repaired. If such things are not there, you can just only debride the labrum and address other pathology. So if it's a degenerative, it's an old thing, it's due to some other chronic problems, just only debride the patient. But if it is less than 40 years, that means age is another important factor. If the patient is less than 40 years, always consider repairing the slap. If it is not, the patient is elderly, even if the labrum is frayed or torn, you try to address the biceps, because in those cases, this labral tear is usually degenerative and the pain is mostly 99% actually coming from the biceps tendon. So three important takeaway points I want to talk to you is that first, look for the biceps pathology, address the biceps pathology, especially in an older patient in a degenerative tear. Addressing the biceps pathology will help to solve your problem. But in a patient, so young patients less than 40 years with a history of injury, that means a traumatic slap tear, always try to repair those slap tears. Thank you. That's I think from my side. So if there is any doubt or any questions, we can discuss. I'll.
Yes, sir. Audience, if there are any questions, please put in
Yeah,
the
I think
chat box.
if they have any questions, they can put in the chat box, or if it is allowed, they can speak up also. No
Yeah.
problem.
So audience, please put your questions again in the chat box, which
We have
I'll be asking
15 minutes of time
her.
for discussions and questions. Right, 15. So I think that the why I choose this topic was that sometimes it's very dilemma to see their MRI report says only there might be a type 1 slap lesion or type 2 slap lesion. So then how to go with that patient? Whether some people inject in those shoulders. I'll request from everyone, please injection in slap lesions in shoulders. Okay.
There is one question, sir. What is the endpoint of conservative treatment?
Right. So very good question. That is a very important and a practical problem we always face. So right. So again, treating them conservatively, two factors. One is that up to stage 1 and stage 2, then don't do in stage 3 and 4, and also the success of conservative treatment is very higher in an old patients who suffered a degenerative slap lesion. But even a young patient or a high demand patient has got a type 2 lesion who is asking that when he can return to sport or when he can return to overhead activities or throwing activities, please try and make him understand that surgical repair would be a better option. So the end point of conservative management is a pain-free shoulder. And always what I do, I always advise these older patients not to elevate the shoulder fully. Okay. So be that they can keep their hand overhead like this and over the back. So that can actually solve all the problems. So, but I always ask not to do them this overhead abduction, because even if a degenerative slap heals or makes your patient pain free with exercise, physiotherapy, and other things, even the patient does it repeatedly, it is going to come back again in older patients. So, pain free acceptable range of shoulder motion is the aim. It's not pain-free full range of shoulder motion in older patients. Whereas in younger patient, pain-free full range of shoulder motion and at least 90% of their pre-injury fitness level should be there. If you can't achieve with your conservative management, always try to look again and plan for a surgical repair.
Yeah. So coming to the surgical repair, sir, how many percentage of the or how many patients achieve success after surgery?
Yes. So I think slap tear, most of them we may, treat them by conservative management. That is 80%. But 20% of them require surgical repair. Those are the young patients. Those are the patient who suffered injury, and those are the patients who wants to come back to their normal level, or the athletes. So if you repair them in a fresh case or within 3 months, then function or the chances of union is almost 100. So their return to their pre-injury activity level is almost 100%. But if it is associated with other injuries like Banker's lesion or cuff lesion or shoulder dislocation, then you might be able to 85 to 90% of their pre-injury level. But the prognosis of slap repair is very, very good.
Right, sir. There is one question from Dr. Sandeep. He's asking, what is the role of steroid injection and physiotherapy in the management?
Okay, so slap tear, there is no straightaway role of steroid injection, because slap, if you can understand, it's the pathology in the labrum. It's difficult to put a steroid injection in that area. But most of the time, this patient has got an associated biceps lesion. That is the message I want to put in your brain, that there is always almost an associated biceps tendinosis, tendinitis, which is the main generator of pain in these older patients, in these degenerated patients. So, in those patients, you can put this local steroid injections palpating the anterior shoulder point or the painful region where actually the most of the pain is. And if you can palpate and if you can identify and detect, it is the biceps tendon where it is actually coming and going through the bicepsal groove. So yes, if it is you can palpate, there is a palpable tender points, you can put steroid injections. That is very, very good for very local pain relief, the control of local inflammation, and can start your physiotherapy and exercise very quickly, which is actually very difficult in those older patients to get back to their fitness level. So there are selected non-diabetic patients where you can put, but it will not going to act for your slap. It is going to act for your biceps tendinosis or tendinitis.
Right, sir. Sir, how much time, if it is an athlete, how much time does it take for return to sport?
Yes. So see, these isolated slap lesions are very, very rare. So what we discussed, it commonly we see it with associated with a shoulder dislocation or associated with a Banker's lesion. Sometimes some problems are also there. So if it is associated with dislocation scenario or Banker's repair and other things, so the return to sports is around 9 months. So to 1 year. It could be of 9 months to 1 year. So at least 9 months. So this arbitrary timeline is not the ideal scenario, but the muscle power, range of the motion, and agility training. That means how much the athlete is able to hold, or how much is the muscle thickness, muscle power, and should be around 85 to 90% compared to the normal side. So if the achievement is done, then only we allow them for doing activity. And if you can understand that principles of tissue healing, 3 months of any that is minimum is required for any tissue healing. And when it is combined injuries like 2 or 3 areas or 2 or 3 structures, so I think it should be around 9 months, not before that. You are muted, Dr. Ketan. You are muted.
Any complications after surgery of slap tear?
Yes. So I'll not say complications. I'll say misjudgment. So where to put your anchor and how much anchor you should use, and either to put the anchor or not. So this misjudgment actually happens, and most of the time, once when there is a banker's list, we repair the bankers first. So we jump and go into the putting anchors, 2 or 3 anchors in the banker's lesion. But once we repair the banker's lesion, joint will become tight. It's difficult to assess the slap. So first thing you need to do, you need to assess. You need to lift the biceps and you need to lift the labrum to see how much it is detached. Whether one anchor will suffice or you need to put 2 anchors, one anterior to the biceps and one posterior to the biceps. If at all you need to put 2 anchors or one anchor, please put the anchor before you repair the banker's lesion. Put the anchor, take the bite, keep the suture. Then you come back to the bankers, repair the banker, tighten the joint, then go back to the slab and tighten your anchor. Because once you repair the banker, your joint will become tight. Then it will be very difficult to assess the slab and repair the slab. So this is the trick you should always keep in mind. So that is why I combined this talk with diagnostic shoulder arthroscopy. Because you need to first identify all the problems, what are their assessment, and then you need to plan inside that, okay, I am going to repair the slab. So if you are going to repair the slab along with bankers, put the anchor, take out the bites, keep it there. Come back to the banker, repair, go back, then tighten down. Then fine. So complications per se is a misjudgment or misplacement or anchor or taking not sufficient bites can cause failure of the repair. So this is the another complications we have seen is the failure of the repair. So it's I think it starts with fail to judge the lesion or the disease proper. So from there it arises. You are muted, sir. Unmute yourself again.
Patient education is very important, sir, after the surgery.
Yes.
So what advice you will give to patients?
Yes.
After repair?
So what I do is that once the patient comes and I draw them a plan that this is the things I'm going to do inside your joint, and see these threads are not going to act like your ligaments from day one. It will help to heal your ligament. Your ligament will be healed by your body only. So whatever my part is done, then your part will start. And sticking to proper rehab is the key of success. It's not the operation I do, it's doing the proper rehab at proper time is the key of success. Then only I will be able to give you a very good result. So that thing, I think, if you can talk with the patient properly, make them understand. And one thing you need to tell them that it's not a magic that we are giving you good results in 3 months or something like that. It will take time. But yes, if it is done properly and if you do the exercise and rehab properly, you are going to get back your proper function.
So thank you, sir. These were the questions. So it was a very illuminating webinar. Thank you very much.
Thank you. Thank you.
And I'm sure audience has also liked it. You have started from the basics and you have gone to the advanced care. So thank you very much. And I now request Mr. Satish to give a vote of thanks. Thank you,
sir. Thank you. Thanks a lot. Thanks a lot, sir. Thanks for the wonderful and illuminating lecture that you had given, and thanks for sharing the time with us today. Yeah, during your busy schedule. And also I thank the audience who have participated today. Yeah.
Yes.
Sir, on behalf of MCure, we thank everyone for the wonderful and lecture today. Thanks for your precious time. Zenex, the division of MCure, works as a rehab champions to support ortho fraternity by offering complete mobility basket, helping patients keep on walking. So we offer an integrated approach in all therapy areas such as pain and inflammation, osteoporosis, and osteoarthritis. So thanks once again for attending and encouraging us. So in this juncture, we salute all medical fraternity for saving everyone's life at these trying times. So as a gesture, would like to play a song which is dedicated for all medical fraternity.
Thank you, sir. Thank you, sir. Very nice.
Thank you. All the best to you.
Thank you, sir. Thanks.
है जाति धर्म क्या सभी का ख्याल रखते हो, बस लक्ष्य है सेवा, सेवा से कभी ना थकते हो, नहीं जान की परवाह, निकले हो जान बचाने को, तुम रोक ही लोगे आंधी जो है आने को। शुक्रिया भारत के योद्धाओं, एमक्योर करे सलाम आपको। शुक्रिया भारत के योद्धाओं, एमक्योर करे सलाम आपको। कैसी ये जंग है, बड़ी मौत सांसों के पीछे, बने तुम जो मसीहा, जगी जिंदगी में उम्मीदें। वहाँ वीर खड़े हैं उन सरहदों की रक्षा में, यहाँ आप डटे हैं इंडिया की सुरक्षा में। शुक्रिया भारत के योद्धाओं, एमक्योर करे सलाम आपको। शुक्रिया भारत के योद्धाओं, एमक्योर करे सलाम आपको। एमक्योर करे सलाम आपको।
Yeah, sir. Thank you. Very nice and illuminating webinar. Thank you, sir.
Thank you, Lord, sir. Thank you.
Thank
Bye,
you.
everyone.